All right, so we're gonna do a criminal justice reform, 802 criminal justice reform short video here on kind of 2021 findings report that just came out when it came to substance use care in the state of Vermont. Um, I'll throw up some visuals throughout this talk, and I'll try to make it less than 5 minutes. But if you look at so all drug related fatalities is what we use in the field, and it's kind of like a mortician determining cause of death when it comes to something like a heart attack or high blood pressure, something like that. Like if you have lots of cholesterol but you have a heart attack, it's like, okay, well, respiratory suppression, was it the opiates or the cocaine or the benzodiazepines? It's difficult for a mortician to really narrow it down. So normally what we say in the field is this person had the presence of drugs in their system at the time of fatal respiratory suppression, probably due to a fatal drug overdose. And we use the word all drug related fatalities normally in the field. And I worked, so I came into recovery, and I don't really identify as a person in recovery anymore. It's just life is fun. I don't really think about drugs. In 2015, on a federal indictment for basically heroin distribution, conspiracy or heroin trafficking out of Harlem in New York City and distributing in Burlington, Vermont. I came in 2015, and that's when the federal criminal justice system started their first drug treatment court. Drug treatment courts date back to the 80s in the state system in Ohio and Florida, and the federal government's been experimenting on them for a while. Shortly thereafter, we appointed Jeffrey Crawford, who's the head district judge. Currently, he presided over my case for something like 2.5 years before he made adjudicated, whatever, sentenced me to time served of I think 30 days, not 31. After 2.5 years on pretrial, he extended my pretrial not an additional year to get to know me more. He thought he had a lot going for me. He didn't think prison time would really do much for me. And we weren't where we could be in the federal criminal justice system, but we or they are very good at their jobs, and I talk about them all the time. And it's not to compare them to anybody else. It's just to say like this is kind of the gold standard of criminal justice right now, especially kind of in the state of Vermont, district of Vermont, especially with what I do, which is try to work with those high level offenders, those challenging cases, those people that maybe habitual criminals or have serious, severe opiate use disorder, severe substance use disorder, or being an initiated gang member, which is something that I do that not a lot of other people do in the state of Vermont. So I use that not to compare and contrast to awesome reparative or restorative panels, I intern under in Lamoille County with things like Tamarack or pretrial services or court diversion, but just kind of like this is the gold standard of what I like to do, which is working with those tough cases, those high level offenders, those people from low income families, initiated gang members, those people that kind of are difficult for a lot of other people to work with. I like a challenge, and I kind of seek out those types of clients. But so that happened in 2015 as we got our first drug court in the District of Vermont, and the District of Vermont changed the way that they investigated, changed the way that they prosecuted, and changed the way who they indicted, and changed how they adjudicated sentencing, and then how they supervised too. There's a different generation that started that year that I was actually indicted in. Fentanyl started about the high levels of prevalence of fentanyl started about a year and a half before I was indicted. So that was 2015, April 2015. So probably 2014, even the end of 13, fentanyl started becoming more prevalent as it just became easier because Mexican cartels wanted to stay relevant in the drug game, and they could synthesize, fentanyl, carfentanil, whatever, or they could import it, unfortunately, from China, and they could get it across the border easier with things like drugs, drug dogs, and border security and stuff like that, because we had kind of cut the supply from heroin or the black powder, the brown powder that was coming in from Afghanistan. And what happened was it was beginning to be grown and imported from South American countries like Colombia or Honduras, and into ports of entry and distributed in a different way, which is actually better, for what we or the federal government does with drug interdiction and public safety efforts and stuff like that, and everything else that goes along with border security or customs and immigrations on the southern border. But what happened is now we're dealing with an increased level of cocaine, prevalence of cocaine, because it's coming in from the border, and from those ports of entry, from places like Colombia that historically have had no problem growing coca in their climate region. But kind of long story short, the prevalence of fentanyl increased in 2013, and then I think spiked at an all-time high when it came to fatal overdoses in 2017. And I was working 2017. I was managing a recovery house, which is kind of like a halfway house, which is a highest level of furlough approved. So when you get released before your minimum in Vermont, even on parole or anything like that, you can get released basically in one of the homes that I was managing, or a home that's funded by Vermont Department of Corrections with a slightly more clinical approach. Those are your options if you get released below the minimum in Vermont, and that's what I did for a living for 3 or 4 years, and I was managing the house then. And me and one of my good friends in Burlington were working together to make an unregulated organization work better, and that's what I've been advocating largely for the last 3 years. And that would have been 2017, and then 2018, all our hard work paid off in Chittenden County, and you could see fatal overdoses that spiked at 133, kind of with that high level prevalence of fentanyl when it came to all drug-related fatalities, or opiate-related fatalities. You could see that spike at 133, I believe, fatal overdoses in 2017. And in 2018, we worked really hard in Burlington. We would meet in Burlington it might have even been every month, from police to prescribers to me and my friends, that were running recovery halfway houses, to I said healthcare providers, to all the different human services, social work people, from harm reduction to probably some mental health, U.S. attorneys, lots of local law enforcement. I don't remember state's attorneys were there, Burlington police chief. We would meet once a month and we would talk about how to deal with the opiate crisis. And in 2018, all our hard work paid off, and we saw basically, I think it was all drug-related fatalities drop 50% in Chittenden County. So I think we were Chittenden County, I want to say it was around 30 when we got it down to 15, and that was 2017 to 2018. And one of the things we did was rapid access to medically assisted treatment. So, like, if you wanted to get help before, it was like years, because people are like, opiates is a serious issue, man. I'd like to get on some type of medication. And it was difficult to find the person, it's not New York City, it's difficult. It's definitely not London or British Columbia either. It's difficult to get in and to get medically assisted treatments, to get Suboxone, to get methadone, even naloxone, or the, it's been a while since I've done this every day. The shot that I actually recommend for people coming out of Department of Corrections, being housed in a facility, if they don't want some type of medically assisted treatment and they think that type of. So I normally use that for buprenorphine or Suboxone or methadone, and then I can go into why I would recommend either prescription for someone in a different talk. But I forget what that injection is called, but I recommend it any day of the week over the pill. And what it is basically naloxone, the other active ingredient, Suboxone. But that's what I talk about when I'm medically assisted treatment is those three things: buprenorphine, methadone, or naloxone. The injection is normally what I recommend, and it lasts for about a month. But rapid access means you could walk into, safe recovery, which does kind of harm reduction stuff. You could walk into the ER, or you could walk into one other place, and I forget where it was, and you could get, a quick prescription for 3 days and access to a healthcare provider who'd kind of be your prescriber for a few months, and so you could get into a hub. And a hub is basically a clinic, and a methadone clinic that prescribes you medication. Then eventually you get transferred to a healthcare provider where you're just going there every couple months, and it's no different than getting an annual checkup or something where you just go see your doctor. And mental health care can be very much the same way, but I mean, if you talk to people like, Sandy Seingard, who's been doing it for decades, you can see like where she was with electroshock therapy versus where we are now versus where we could be, which is kind of like lagging behind opiate treatment, because mental health gets less of the spotlight because of what we're talking about here with all drug-related fatalities. But so 2017, you see 133 fatal overdoses, and then it drops down to something like 100 or 95 or something in 2018. And a lot of it had to do with us in Chittenden County leading the way, or being the forerunners, and working very, very, very hard and very diligently to get that 50% reduction. And 50% is unheard of statistically. So the other big thing that you hear about with 50%, where you're like, what is Icelandic prevention? When Iceland got their youth prevention to kind of drop 50% usage, I believe, with alcohol and tobacco. But I've done my own studies on that. I just haven't gotten them published in terms of a peer-reviewed study. That has a lot to do with, lawsuits with tobacco and the prevalence of drinking with minors, and kind of global phenomenon that kind of went along with policing procedures and everything else. It wasn't just Iceland, instituting the Icelandic prevention model of youth prevention services. They also did a lot of like tough on crime stuff to get that 50% reduction. But 50% is pretty unheard of. And what Chittenden County did was rapid access to MAT. Was a big part of it, and the way we did recovery housing was another big part of it. But there's a lot of stuff that we did kind of in 2017 that got those statistics in 2018 to get 133 fatal drug overdoses down to, I think 95 or 101, 103. So something else that we did was physicians changed the way that they prescribed opiates, and kind of behind the eight ball on that in Vermont, because a lot of, there was stuff in Barry, if you read the book Dope Sick and you kind of look at the prevalence of that kind of crime and things like that in Barry, but a lot of us would go down to the pill mills in Florida at the time and bring them up 95 or get them shipped to us in the mail and that type of thing when it comes to distributing pharmaceuticals. And if you look at the laws of relevant conduct and stuff like that, a lot of them are designed around people in Medicaid fraud. So it's about the amount of pills that you can sell in 2 hours. So if you look at 2 hours and you look at what you should bill from Medicaid, billing, it's interesting to think about the amount of pills that you can sell in 2 hours with the DEA trying to get stuff from your Medicaid billing. It's really fascinating stuff if you check out the laws of relevant conduct. But that was over and done with. A lot of that stuff was curbed by kind of, I'm trying to think, 2010 even in 2010 they changed, I think, how Oxycontin was being produced in a more generic form, so it was more difficult to abuse. So it was just, pills were less of an issue, but we were still trying to like take it on the way that we prescribe for acute pain, not chronic pain, when people came into the ER, by basically like shaming physicians and stuff by putting up like, hey, listen, this is how many pills you prescribe versus how many pills so-and-so prescribed. Put on like a flow chart on the wall. It's like, hey, Steve, bro, what are you prescribing for the catamounts? Like, you prescribe 47 prescriptions. Like, word on the street is they had a rough game against Merrimack. Like that's one of the things that the University of Vermont Medical Center did, to have physicians take a look at their prescribing practices, as well as just a lot of data with like different graphs and things like that. But we also targeted human trafficking, for women, that might have enjoyed sex work but were being paid in drugs. And if you talk to me about sex work, I have a different opinion on that than probably a lot of people, but I'm pretty far left. I'm so far left, I'm right with a lot of things. Always right. But that's kind of stuff that we did in Chittenden County to get those numbers to change, along with drug treatment courts and the way that the federal government was prosecuting and indicting and adjudicating and all that stuff, especially in that county, at the time. This is stuff that we did in Chittenden County as substance use professionals, working with law enforcement, working with healthcare providers and stuff, to get all drug-related fatalities to drop from an all-time high of 133, I believe, in Vermont, down to something like 103 or 95. And we were pretty happy with our work. But the topic of this discussion is why in 2021 we have an all-time high again. And I haven't looked at the actual data for prevalency of specific substances when it comes to amphetamines, cocaine, opiates, whether or not they're testing for fentanyl. Benzodiazepines is a big thing, but that's a time for another lecture. Vermont typically does a better job than the rest of the country, and a much better job than England when it's talking about fatal overdoses with the prevalency of benzodiazepines. Prescribing practices and stuff like that, I can't really speak to as a professional, but the subject of this talk is going to be about the 180 or 181 all drug-related fatalities in 2021. And it's going to, the focus of the discussion isn't just going to be on why those numbers are high, but it's going to be on criminal justice reform. It's going to be on Vermont Department of Corrections policies, policing procedures and stuff like that. And it's going to conceptually speak to that. Because right now I'm on the outside. I mean, I'm an independent freelance advocate. I own my own consulting firm, and I can't have access to someone's data. I don't know the procedures. I'm involved in a legal battle with the state of Vermont right now because they didn't want to give me data so I can do this. Constitutionally, I shouldn't be silenced in the media. I should have access to this type of information before it comes to protesting, before it comes to conscientious objection and Black Lives Matter and defund the police or any of that. But that's just constitutional garbage if you want to hear me lecture on data and statistics. So that's kind of where we were at. And then in 2019, 2020, you can probably see that stuff trending down or staying pretty normal. Well, we went to the few remaining counties to set up a hub for medically assisted treatment and try to increase healthcare providers for spokes in Burlington, Vermont, where a lot of people get referred to upon release from the Department of Corrections or jail or prison, upon release from Bureau of Prisons, federal prison, coming back into the state of Vermont. From an outside facility or being released from rehab or different county trying to go to a residential treatment facility, inpatient, whatever, and then being released to Chittenden County because there's more services there. There's a bus line there, and so we were working on kind of having healthcare providers that could prescribe more of them, which is why APRNs or nurse practitioners are much more prevalent. And mental health too, but in substance use when it comes to getting a SAMHSA waiver to be able to prescribe Suboxone. All right, it is I, the domestic terrorist and verbally threatening menace that fights for sport. Here to school you, bro, on why I think statistics were almost double what they should have been in 2021. So I walked away. I mean, I'm just the best at what I do. People want to be like me. They want to look like me. They want to talk like me, and they don't. I walked away at a principle in 2021 from my field, which is specifically opiate use treatment pertaining to the criminal justice system. That's what I studied at CCV extensively. And it's because a lot of this was the best way to enact social justice for criminal justice reform when I was going to school. But in 2021, what happened was COVID, and there's a lot of things to talk about with COVID when it comes to even domestic violence or kind of psychological trauma and damaging effects of solitary confinement when you hear me lecture about this type of stuff. But like the important thing to realize is it changes the way you do policing, because when you're policing in a certain manner or you're promoting a public safety effort in probation in a certain manner, what it does is changes the amount of people in the influx or outflux of Department of Corrections, jails, and prisons. And the reasons that you have to do that with all these executive orders coming down from the president or the governor's office when it comes to COVID contamination is if this was even something deadlier, we could be in hot water, it could not be easy, but you had to take a look at, what Vermont Department of Corrections had to do and what people had to do in order to prevent the spread of a contagion. Because if you look at Russian prisons, something that happened was antibiotics weren't readily available, and doctors would try to prescribe some antibiotics, and what happened was, I forget what it was. It's a bacteria that they test for it when you're in facilities and things like that. But it became basically a super version of that because of the prescribing practices of people in Russia that didn't have the appropriate amount of medication, and now it can't be treated. And it's something that you have to worry about, the spread of that type of thing, as well as things like MRSA when you're incarcerated. But it speaks to the spread of that type of diseases and things like that in facilities like jails and prisons. So when you're trying to contain COVID, which is a very infectious outbreak, we had to come up with a procedure to do that. And I'm just going to talk about like policing procedures and policies and what I've seen and conceptually how that works, because I am not being granted access to that type of information as an independent consultant or freelance advocate that owns a social justice consulting firm. And that's the battle I'm having right now with the state of Vermont. And that's why I basically had to tell the legislature that they owed me about 40 million with my hand going shit. But like long story short is this is conceptual stuff. I'm not being released that information. I'm actually kind of ticked off about it. So what happens is if you're trying to like prevent people from going in and out of jail, like first of all, stays will probably be longer, and specific units and stuff I think were created, but it's really difficult with the temperaments of people who are incarcerated and stuff like that to house people based on just length of stay when you're trying to get people in and out. So the people that are in, you kind of want to stay in, until you can kind of get stuff to settle down when it comes to the different things like that. And then you're just trying to keep people out of there, which is actually my job. But what happens in a public safety effort when you're working probation, which is largely my job, is working with probation to make sure the public stays safe, and then I work with the individual to try to help them, is probation is trying not to violate people. And that is my biggest thing, is how not to have to violate our clients, to have them stay in the community, because it completely ruins their life. They have to start all over again. They get socialized in a condition where criminal behavior and criminal deviance is accepted, and there's bad peer influence, and there's limited resources to kind of help them get away from that lifestyle, even if they want to. So just those short incarceration stays and violation stays are just awful for the clients and their success in a public safety effort. And it does in Vermont. My rounded figures are something like 450 needless incarcerations every year. And what happens when you incarcerate 450 people needlessly is you start, a private prison contract in Michigan. And nobody likes going there. That's slated for up to 600 people, where there's currently around 270 people. And that's one of my big things is I don't like that prison. I don't think we need it. And the people that work there could probably get better jobs at Chick-fil-A. So that's what happens with needless violations. So when probation is trying not to violate you, one thing that they've done is cannabis, and it's one of the reasons why if you look at the judiciary reports, you'll see the violations and time spent on violations, I believe, go down, because the judiciary in violation hearings or whatever are going down, largely because a lot of people in the state system are okay with their clients using cannabis, since it's not just decriminalized, but trying to be legalized in the state of Vermont. And I think there's a way to protect federal banking systems in the state of Vermont, but we'll have to take a look at that, like protect that money. I think there's a constitutional change to protect cannabis money in federal banking, but we'll have to take a look at it closely. We can change the Constitution to protect that money. Long story short, when trying to prevent unnecessary violations, there's less violations that happen in the public safety effort with probation, which probably means they're probably spending more time for a public safety effort. But and that's great, but it's difficult without proper case management like I've done to have the person not do stuff that makes the public less safe. And the state of Vermont's done a lot to try to work towards that, and they have those positions available from Tamarack to reentry to pretrial service coordinators and stuff like that. But I'm not running one of those programs for a reason, and the reason is I own a social justice advocacy consulting firm. Because as a case manager, when there's big holes in the system, I'm ethically obligated to try to address those holes and enact social change, so my clients stop reoffending, no matter how good I am as a case manager and residential counselor. But basically, what I'm talking about is less violations while trying to keep the public safe, in order to keep COVID contained and keep kind of the level of people incarcerated probably the same, but have it be the same people in those facilities, so you prevent people from going in and out and spreading a very contagious disease pretty rapidly. And what local law enforcement does is it's kind of hands off, especially when COVID was really going and really contagious and really deadly. There was a definitely hands-off approach towards incarcerating people.
when it came to, that type of policing procedure and stuff like that. So what happens is, without what I proposed and why I was protesting in Montpelier and what I've been doing the last 3 years as an independent advocate, you have less people going into jail. So you have less of those violations, which I'm protesting. And I'm sure there's lots of statistics that prove me wrong. So when you have less of those violations, for like, if someone uses drugs once, or they're using drugs, normally the state's response is to violate them, and it's actually, anybody's response. And then they go to jail for 3 to 5 months, and those are the statistics I talk about with closing the private prison and kind of a $40 million budget suck at the state of Vermont, and the District of Vermont, that the state of Vermont, spends that type of money to house those types of people, regardless of where they get it. So you're having less of those violations, those 3 to 5 month violations, which is what I want. But the prison population is probably saying similar. But the issue is, those people don't have services. So, if they're in a recovery house and they relapse, if they're in, an FSU approved housing and they're struggling with their substance use disorder, but they might not meet ASM criterion yet, which is what I do for a living. What happens is those people are at risk for fatal overdoses. Those people are at risk for an armed robbery. Those people are at risk for burglaries and other petty crimes that they use to fund their habit, because a lot of them won't want to sell narcotics at the level that they used to, or they're at risk for going back to that lifestyle crime of selling and distributing narcotics if they've accepted that or okay with it. And they're doing that because they're not being removed from the residence and put into a secure facility for 3 to 5 months. And what happens when you're not being removed from your residence and being put in a secure facility for 3 to 5 months, if you don't have the care that I proposed 3 years ago, is you overdose when you start using those drugs. So you can see fatal overdoses in 2021 go from something like 90 or 80 up to 180 or 181 as of November. So in 2021, you have something like 200 fatal overdoses. And conceptually, with what I do for a living, a lot of it is probably policies in a public safety effort to prevent the spread of COVID, of not having those needless violations, but not having the support set up to have those people have crisis services and have substance use treatment, or have people that they can turn to before their use becomes an issue. And what results is they end up overdosing, and the statistics should not be anywhere near that, and they should not be anywhere near that for a reason. The prevalency of cocaine, I can pretty much guarantee you, is much higher, and it's difficult to say, hey, listen, this is the prevalency of cocaine when you look at all drug-related fatalities or other statistics. And it's difficult because less overdoses result from cocaine usage, and cocaine is normally out of your system in 3 to 5 days, or as much as a week. So it's difficult to say, like, this is prevalency of cocaine when looking at statistics. But I can tell you, it's using social imagination and using, social theories, and just from my own anecdotal observations, the prevalency of cocaine is much higher, especially with isolated relapses. So if anything, fatal overdoses involving things like fentanyl should be going dramatically down, not dramatically up. So people are overdosing because they don't have care, and the care that they don't have that they had in the past was needless incarceration stays of 3 to 5 months. That's essentially what I'm saying. Less people are being violated, but more people are overdosing because they didn't have crisis beds. And the state of Vermont's worked really hard to, at least in Rutland, do a program where you can offer them a hotel room and then have hopefully case management. I was working with Safe Recovery to try to set this up years ago, and hopefully they're still on this. There's amazing, hardworking, beautiful people out there that work very hard to do this. But, when you get a case manager, you can get referred to a landlord that hopefully is used to some partying and stuff like that, and is willing to kind of rent, a cheaper place that might have to get fixed up. Because you need a referral from that hotel room, if you're meeting criteria from that hotel room, to a landlord that's willing to, house you. And what that does for me is it allows me to make a referral depending on a risk assessment and my own questionnaires or assessments, with hopefully financing from probation and parole or other things, to set you up in an apartment, which may or may not be better for you depending on your usage and the risk assessment of what that usage would look like. Because if you want to use a harm reduction approach, and this is something I advocate for and something that I'm, on the record and saying, I haven't been published in my opinions, that's to come in my second and third pieces. But, with a harm reduction approach, you can't stay in an FSU approved housing, like a recovery house or a dismiss house or a Phoenix house or a halfway house, you need an apartment. And I make referrals to those types of apartments for other reasons too. But a lot of the state of Vermont setting up right now with more safe usage through that program of the hotel rooms is working with landlords that are kind of used to this stuff, having a place to stay, so people like me and case managers at Safe Recovery can set up harm reduction plans, not plans that are based on abstinence that, make room for isolated relapses. Because if the person just wants to use even cannabis in a harm reduction program, a recovery house is not the place for them. And normally, if you're getting released on furlough, you're a higher risk, and your level of housing needs to be like a level 3, which means you can't go to an apartment, period.